think I'm good now. I just came back out and went back in.
Okay, we're good.
I think so.
All right, let's go.
Let's go. All right, I'm muting. One minute. Okay, I'm going to admit all and hit record.
Good afternoon and welcome to the second virtual convening of the Kansas Rural Health Innovation Alliance. Before we get started, I have a couple of housekeeping items I'd like to share. You can use the Q&A feature to ask for questions and drop your comments and thoughts in the chat throughout the meeting. The session is being live streamed and recorded for technical and content and follow-up purposes. Portions are also being live streamed, as I mentioned, for members of the public to view. If you have any technical questions about Zoom, please find Lindsay Burkhart, KHI IT Help, and chat her in the participants list. All right. So hi, I'm Sheena. I think many of you met me last week, but I lead the Access to Care work at the Kansas Health Institute, and we're supporting facilitation of today's meeting. Today, I'm going over the agenda, then we'll have some welcoming and opening remarks from Secretary Stanek and Secretary Howard with KDHE and KDADS. I'll then provide a meeting overview and context, and we'll have a couple of group discussions focusing on finalizing the vision and mission and values for the Alliance. In addition to a review of the application structure and stakeholder input process, it will provide a preview of what to expect for the whole application. We'll have another group discussion about funding pools, and then we'll close with the second half of the meeting being in breakout room discussions based on key topics to get feedback and input on areas of the application. Then we'll share what we heard in the breakout discussions and discuss next steps for the stakeholder engagement process. Today's objectives include reviewing updates and rules related to the application process, reviewing the current application content and providing feedback based on criteria, suggesting refinements to elements of key components of the application, and identify any missing elements or areas where additional information might be needed for the plan. Then we'll prioritize which elements that would be interested among that stakeholders would be interested in for including in the application. And now I'll turn it over to Secretary Janet Stanek with the Kansas Department of Health and Environment and Secretary Laura Howard with the Kansas Department for Aging and Disability Services to kick us off.
Hey, good afternoon, everyone. On behalf of the governor, KDHE and KDADS, we want to welcome you here today. Second virtual meeting. We're very excited with the results of the first one, and we want to thank you for your time. We know everyone is very busy. This process is supported by you. You are a governor-appointed Rural Health Innovation Alliance. We want to include a broad range of rural voices and expertise, and we appreciate that again. I'd like to express also our sincere appreciation for you to continue with us on this journey. Engagement ahead of the application is one thing, but we're going to need that engagement going on because we do plan on receiving funding of some sort. So the insights and ideas and expertise that you share with us will help us shape a strong Kansas-centered vision for rural health transformation, and we want to truly reflect the needs and the abilities of the Kansas system. At our first meeting, the focus was on developing a shared vision and mission, and we discussed key topic areas that will form the foundation for the application to CMS. Today, our plan is to build upon that foundation. You're going to get an update and review the application process, what the assessment is of our proposed focus, both the feasibility and innovation for those, and identify where additional detail and refinement will be needed. I can't emphasize enough that we recognize that this is a very fast-moving process and a lot of interconnected pieces. Your time and expertise are invaluable. We want to make sure that we capture as much as we can to come up with an application that reflects the needs of all. We have designed today's agenda and feedback tools to make the most of the time together. We want to gather, again, as much meaningful input as possible so we can quickly turn around, and in some cases, we're turning around things within 24 hours for each other just to keep track of all of the moving parts that CMS requires in this huge application. For those joining by a live stream, we welcome questions and feedback, and you can direct them to kdhe.info@kansas.gov. I'm sure that's in the chat. We're moving quickly again, but intentionally to meet that timeline. With that, I would like to turn it over to Secretary Howard for her to say a few words and to continue on for today's discussion. Thank you.
Yeah, thank you, Secretary Stanek, and welcome everybody. Glad to be here with you today. We missed the first meeting last week due to some travels, and was really pleased to see the progress that the group made. So just a reminder of where we are in the process. Right now there are individual meetings with stakeholders that are wrapping up this week. Obviously the virtual convenings last week and the one today with a focus on reviewing and refining key elements. Next Monday, we'll have an in-person convening, really coming together in person to walk through the draft application, collect final feedback. And then a key point I really want to highlight, I just said collect final feedback, but there will be ongoing opportunities for engagement, both in the coming days and throughout implementation. The involvement, the engagement, the feedback from this group doesn't end once the application is submitted. Your ongoing participation is really going to be what's key as we refine and carry out these priorities in Kansas communities. The drafting and review process, October 24th to November 3rd by the application development team and the interagency task force, and then hitting that magic date of November 5th to get that submission into CMS. So again, just to stress again, once the application is submitted, we'll continue to create structured opportunities for engagement and feedback. It's so important to continue to hear the voices of rural providers, hospitals, community organizations, and that's really central as we move from design to implementation. As a reminder, the Rural Health Transformation Program application is a coordinated effort led by KDHE in partnership with KDADS and the University of Kansas Health System Care Collaborative, really working together as that application development team. We really are integrating your input, refining concepts, and drafting the components of the statewide application. Again, keeping the vision for the program in mind. And that really remains clear that this is really about transforming rural healthcare in Kansas through sustainable, community-driven solutions. And those really need to be things that improve access, strengthen the workforce, and foster innovation. And those also need to not just be transformational, but the design initiatives also really need to be practical, right? Really meeting our rural communities where they are and giving them the tools to thrive for years to come. So as we transition into the meeting, I just want to once again say thank you for your partnership, your leadership, your engagement, your time. We're really not here just developing an application. We're making a long-term investment in the health and resilience of our rural communities. So thank you for your engagement so far. I encourage you to stay connected, keep sharing your perspectives, and help us carry this momentum forward. With that, I'll turn it back over to Sheena to guide us through today's first group discussion.
Thank you so much, Secretary Stanek and Secretary Howard. Thanks for welcoming me in the group and providing a vision for transforming rural health in Kansas. All right, so I think we'll go ahead and get started with the first discussion. We are going to be finalizing the vision and mission and values for the Alliance.
Excellent.
Hi, Marty. How are you? I'll turn it over to you.
I'm great, Sheena. We're under 2 weeks now, so it's an interesting time. But thank you, everyone, for joining us today, and really just picking up exactly where we left off last week, starting with a review of the draft vision, mission, and values. Hopefully, you've had a chance over the last week to sit with these, contemplate them, and be willing to provide feedback. So begin with the vision. So this is why we all are coming together and submitting an application. What is our vision of what we can accomplish? And here we propose that rural Kansas communities will thrive as residents are able to lead healthier lives and have ready access to coordinated, comprehensive healthcare services. So we'd like the feedback from the group in terms of too many words, not the right words, not the right direction. Any way we can refine this to make it more reflective of what we as a group believe we're trying to accomplish. And if we did folks just want to unmute their lines and jump in or add comments in the chat? And
Yeah. Yes, feel free to add your comments in the chat. Any final tweaks to the vision that you might suggest?
well, we don't want to cut off discussion. And of course, at any time, you're considering this and identify a way to refine it, please share with us. This is not your one and only opportunity, but let's go ahead and move forward to the mission statement then. So as we discussed last week, this mission statement is derived from the 5 strategic goals that are identified by CMS in the Notice of Funding opportunity. And any good grant writer will tell you that to the extent you can mimic back to the organization that is offering the opportunity, what they identify as priorities, that is certainly helpful to the application. But in this case, it also really paints a broad picture of what we're attempting to accomplish with the mission of this rural health transformation plan. So here we want initiatives that can address preventative health, both primary prevention and secondary prevention. Primary prevention is to keep you just healthy as could be, Secondary prevention is to keep you from getting worse if you have a chronic disease or other condition. In addition to preventative health, we also want to address the root causes of disease. Then we talk about enhancing providers' efficiency and sustainability, our ability to attract and I'll say it right yet, attract and retain a high-skilled healthcare workforce, and spark the growth of innovative care models, and importantly, foster the use of innovative technologies. Again, I believe we emphasized this last week, but we'll go back to it again. Very heavy emphasis in this notice of funding opportunity, as well as statements made by CMS officials that technology needs to be a critical component of rural health transformation plans. They see that truly as the future for expanding the capacity and capabilities to serve rural communities, and see this truly as seed money, as venture capital money for communities to make those critical investments to advance technology.
Thank you, Marty. There's a comment in the chat. It says quality, coordinated, and comprehensive care. Also, the effectiveness of the system of care practitioners and systems is desirable. Needs a bit of wordsmithing.
And this is Kiana. What I was saying needs wordsmithing is my mention, not words.
Oh, okay. That makes sense. Thanks for clarifying.
Yes.
Kenny, you're going back to the vision
The
statement,
vision.
correct?
Yeah, can we go back
Yes, I
to the
was
vision?
sorry, I'm a little slow. Was thinking, yes.
So access to high quality, coordinated, comprehensive healthcare services. Is that where you're focusing in that quality comment?
Correct, for the quality. And it was mentioned very aptly last time that we convened. Someone said, what about the providers, the practitioners? And so I don't think a vision statement should be long, but I do think the effectiveness of the system of care is important for what it's worth. Thank you.
Mm-hmm.
Well, focusing on that word healthier kind of does that already. To me, saying healthier lives is more or less, I mean, talking about the quality. Just my thoughts.
Any other thoughts or reactions for the vision?
Sheena, this is Ed. I just want to convey on the vision. I'm slow too, Kiana. Don't worry, I'm still on the vision. I loved your comments, Kiana. I think the words ready access to coordinated, comprehensive healthcare services are really profound and imply so much. And I just love it. And I think it's just really important. It implies so much. To me, it implies transformation, which I know, Marty, you keep telling us we have to show transformation in this, but I also think it implies we have to have good, stable services too. So I just think that that phrase is really powerful and means a lot.
I'm sitting here playing with words, and I think if we went with have ready access to high quality, comma, well coordinated, comma, and comprehensive healthcare services. Does that hit the mark, folks? And again, I appreciate you're looking at this, and if you're like me, it takes a while to get the editing brain going. Sir, additional feedback would be great on this. So, but let's hop back over to the mission statement. And again, the content here is driven by the strategic goals set by CMS for this overall program. But if we can say that in a more specific manner, if we can give it a Kansas twang, shall we say? If anyone has feedback specifically on this, please share.
Marty, this is Chad. Just looking at the mission, it seems like, obviously we touch upon all the key areas that we've heard about during the last meeting, whether it's talking about sustainability, the workforce component, and looking at innovative models and technology. I think it kind of hits all the key buzzwords from my perspective.
We really could call this the buzzword statement. I have to admit, Chad, that's kind of its purpose at this point. But all of which buzzwords are critically important, but we are at this, in the drafting of this, truly trying to focus in on where CMS wants us to be focused.
I can give you another minute or so to think it through, and please put your thoughts in the chat, or please verbalize any comments you'd like to share related to the mission. Doug says, I think you can add availability to the description of rural providers, as there's a shortage of providers.
So I think that would be attract and retain an adequate number of highly skilled. I think, is that where you're going with that comment? Is we're trying to add a quantity component to that attract and retain a high skilled healthcare workforce.
Mm-hmm.
Is that, whoever made that comment, I apologize. Is that where you're headed with that?
The comment was from Doug, if you're on and want to come off mute. Enhance rural providers' efficiency, sustainability, and availability. Oh,
I think
the second,
I'm
please.
just trying to make sure we have a focus on improving the quantity of primary care providers in the rural healthcare first. So, and I understand that attract and retain a high skilled healthcare workforce does include that, but workforce is not just providers. Workforce is pretty broad. So.
And Doug, as we get into the objectives, you'll see on the workforce component, some work that the Kansas Hospital Association has been doing there. They've really refined it down to focusing on those ratios of primary care to population. And hopefully that drills down specifically on that issue. But again, I will definitely play and try to do some wordsmithing and add that component here because it is critically important. Absolutely. Okay, Sheena, what's next on our list then?
Next on our, and others are making comments saying that
Okay,
mission
good.
statement is consistent and general positive response. So we will move on to the values next.
These are the same. This is 3 of the 4 are the same value statements you saw last week. But we did some work on number 4 in response to comments that had concerns about placing a limitation on only using funds in rural communities, because in fact there are urban facilities with which rural providers work closely, and there may be important investments to make at the urban level for purposes of benefiting those in rural communities. So rather than that very black and white statement, we try to look instead into the wise use of funds, implementing as efficiently as possible, wanting to maximize the benefit to rural communities, so that every dime spent, we have asked ourselves, is this the best way to spend this dime given the rural communities we're trying to benefit? Is it the most efficient way to accomplish the objectives we're setting for ourselves? So that was the revision to that 4th value statement. And again, the value statements become critical because these are our guardrails. So as we consider specific projects, specific programs, we are forced to make value choices. This one in, this one out. Because though it seems like an unlimited amount of money, a $200 million budget still has some constraints to it, as Jody will tell you, as she's been working on the budget. So we do have to make choices. And that's the purpose of these value statements, is to inform our decision making. So what's our true north as we look at these different initiatives?
Carrie has her hand up.
I do. Hi. Thank you. Hi, Marty. Hey, I wonder about in the fourth one, and I appreciate the change or the amendment. Talking about proven solutions, I'm thinking about some of the pools that are being proposed that might also invite promising practices or the potential for pilots. Is it important to use for the promotion for the applications purposes only those solutions that have a strong evidence base, or is there room for promising practices or innovative solutions as well? In which case I might just tweak that wording a little bit.
So change proven to promising,
Or
both proven
and
and promising.
Yeah. Or
There's
innovative, perhaps, instead of promising. Yeah.
It's sort of, I'm trying to think back to specific provisions in the NOFO, because it does sort of have both angles to it. They want it to be, we don't want you experimenting necessarily. But I think if you have promising, it's not necessarily causation, but it looks like correlation. I think that would be appropriate. I think, and as we talk about the funds, that is exactly where we're going, because it is opportunities within a community, within a region, to some degree to try experimentation more along the lines of, we've never worked together this way before, which isn't necessarily a proven strategy, right? It's a promising strategy that we could do that. So I like that idea of saying proven and promising.
Thank you.
Others?
Marty, this is Chad. I think Carrie mentioned whether it's proven and promising or proven and innovative. I think either one would be appropriate. And I appreciate the fact that it still kind of focuses on to maximize the benefit to rural communities across the state, which is ultimately kind of what we're looking at doing with the Transformation Grant Program. So I think it's really important to continue to emphasize that. So I think the change that you made seems appropriate to me.
We have a few minutes left, so I think now is the time where if we can maybe show the vision, the mission, and the values again, and just get any final suggestions, thoughts, and comments, then I believe the plan is to make the final edits to those and have them to present to you on October 20th. So again, I'll read the vision statement. Rural Kansas communities will thrive as residents lead healthier lives and have ready access to coordinated, comprehensive healthcare services. There's a slight change suggested there that will be incorporated. For the mission, a change that was suggested would be to incorporate the word availability around providers' efficiency and sustainability. There was also another comment for including the following phrase after attract and retain a high-skilled workforce, to add the words at the top of their scope. It was referenced in the application that was suggested by Brenda Sharp with REACH. Okay. And then for the values, another possible tweak to the fourth value would be to add in the concept of proven and promising solutions to account for those that may be promising but not yet proven, in the spirit of innovation and transformation. Okay. Thank you to everyone. This is really high level stuff, and I think it will help not only provide a clear path for the application for Kansas, but also when thinking later about the programs and the projects that are going to be included, these values can really underscore all of those to make sure that there's a clear vision and plan for Kansas. All right, we can go ahead and move on to our next agenda item. So next up, we're going to spend some time reviewing the application structure. So now is where we get a first preview of what the application is looking like and how it's organized. And so I'll turn it over to Marty for that discussion.
Well, sometimes you just have to pick a horse and ride it. And that's what we're doing at this point, because just by way of background, the Notice of Funding Opportunity provides instructions on the project narrative, which the primary purpose is to state your need and then to state your solutions that are within the initiatives that comprise your plan. And the plan, which again is the document for which we're seeking approval and funding, is really, at the end of the day, the initiatives we've selected and the governance and management structure we wrap around it to achieve implementation and then sustainability. And the initiatives, as we discussed, are driven in large part by those 10 initiative-based factors that are identified in the Notice of Funding Opportunity. So CMS has told us, we want your plans to address these factors. And in fact, we're only going to fund initiatives that reflect those factors. So if you want to take the money you receive and how you budget have to be tied to initiatives that again are consistent with the factors, because this list of factors are playing two roles in the application. Part of it is, and what we've been really focused in on, is you have to hit the factors, score the points on the factors, because that's going to comprise 35% of your score that determines your workload funding award. Right? We all get the base funding award. It's that workload funding that we're trying to chase, maximize our points to ensure the greatest award possible for our initiatives. But those factors are also effectively providing the parameters of what can be included in the plan, that we have to tie our initiatives back to those factors in each case. So the instructions in the NOFO state how to describe an initiative. So it goes through the requirements for it. It provides examples of potential initiatives, but then subsequently CMS has said in FAQs that those examples provided are only at a high level, and their expectation is for a much more significant level of detail to be presented in the initiatives from the states. They also say that the goal here is not to have the most initiatives. It's not going to help your score if you have 10 initiatives or 20 initiatives or the like. So as we contemplated how to organize this, to how to present the plan in a cohesive fashion, we tried to think, well, what constitutes an initiative? How do you get your hands around that? Is every single proposal and project that people have brought forward, is that an initiative? If that were the case, to use up the budget, we could literally have 50 separate initiatives, which of course becomes difficult to really run a theme through that and tie it together and make it look like a plan. So what we are focusing on is this graphic that you see on the screen, where we start with those 5 strategic priorities that CMS has identified clearly and repeatedly in the Notice of Funding Opportunity and in the webinars that it is sponsored today. So those 5 strategic priorities, as we just discussed, inform our mission statement, but they are also then going to create the objectives for our plan. So for each of the strategic priorities, we're going to define a specific objective the plan intends to achieve. Those objectives lend themselves to initiatives, right? If I have an objective I want to achieve, I'm going to design an initiative to accomplish that. So that gives us, we have an objective. Here's our initiative. This is what we want to achieve here with the initiative. We define that initiative by the outcomes we want to achieve. So this is where we're now getting down to the level, not necessarily at a metric, not to a reportable metric where we provide a target and a baseline, but we say we know we've achieved our objective through the initiative if we achieve specified outcomes. Okay. How do we get to the outcomes within the initiatives? That is now at the level of programs and projects. These are the component parts of initiatives that become the action plans for implementing the overall plan. As you'll see, program is at this level. A program may be, for example, I'm trying to think of one, Jody, from the budget, and I'm completely blanking right now, but we have a program level.
Medicine, Marty.
Which one?
How about food is medicine?
Food is medicine is at a program level. So it's one of the ones that had a project level. It would be preventative care, right? Preventative care is one of the programs that would be under the first objective. And so the projects under preventative care are the very specific interventions that would be pursued as part of the plan. That all looks very confusing in a very a fashion like this. So let's, Sheen, if we go to the next slide and sort of look at how these actually work. And so what we have then and this is on 2 slides, correct, Sheena? Right, we've got another slide
Correct.
that's 4 and 5.
Yes.
Okay.
Yes,
So,
that's correct.
so this is to give you a better feel of how this works. So we start with the column on the left is the strategic priorities, copied directly out of the NOFO. So first strategic priority is implement and sustain initiatives that promote preventative health and address the root causes of diseases. That's going to sound really familiar because you just read that in the mission statement. The objective then, how we're going to implement that strategic priority that we propose is realize meaningful reductions in chronic disease rates, as well as avoidable hospitalizations for complications related to chronic disease in rural Kansas. So it's a 2-part objective, right? We're going to reduce disease, the rate of chronic disease, right? Keep people healthy, avoid chronic disease. And then for those that have chronic disease, that we're managing them appropriately, and sort of the target metric for that is this idea of avoidable hospitalizations for complications relating to those chronic diseases. So how do you know you've managed a diabetic well? They don't end up they're not hospitalized for complications related to their diabetes because it's being managed appropriately. So then the initiative, what we're going to call the top level initiative that ties back to that strategic priority, is to expand primary and secondary prevention programs in rural communities. So same thing, go to the second strategic priority, which is enhance rural providers' efficiency and sustainability. Here, the metric, again, the objective, which is how do we put that in a measurable framework, is to substantially reduce the number of rural Kansas hospitals with negative operating margins. Now, granted, focusing on a particular type of provider, which is the rural hospital, but appreciating that in most communities that the financial success of that hospital, other providers are very dependent on the financial success of that hospital. And again, history has taught us when you lose a hospital or a hospital begins cutting services because of financial strain, then that impacts the entire healthcare ecosystem in that community. And so to come up with an objective, how do we really measure sustainability of healthcare? Our measure here can be improving the financial performance of hospitals and objectively accomplishing that by reducing the number of hospitals with negative operating margins in Kansas. Now, another opportunity here, of course, would be, as we referenced previously, ratios of primary care providers, behavioral health providers, or dental providers to the population. So to kind of eliminate those shortages so that we can ensure sustainability. We're going to mirror that in the workforce initiative when we get to that. So that was, we considered that as we were drafting these proposals as, well, should we be looking more at the actual individual provider level as opposed to the facility level? But for this objective, we thought we could focus in on the opportunity by looking at specifically the hospital's financial condition. And the initiative around that, of course, then is securing local access to care. Number 3 strategic priority is the workforce, attracting and retaining a highly skilled workforce. Again, language sounds familiar from the mission statement. And here, the objective is improving that provider to population ratios in rural Kansas, as well as easing nursing and allied health provider shortages in rural Kansas. And the initiative there is built around having a sustainable workforce. Sheena, next up, I'm sorry. Number 4, strategic priority is spark growth in innovative care models. The objective here mirrors an objective that CMS adopted a couple of years back of having 100% of Medicare and Medicaid beneficiaries in rural Kansas in accountable care relationships by 2031. So all rural providers having that opportunity to participate in some form of an alternative payment model, whether that's a pay-per-performance model, a shared savings model, an episodic payment model, a capitated model, a full risk model, a partial risk model, a direct-to-employer model. There's a whole range of these accountable care relationships, but what's critically important here is giving folks the capacity to accomplish that. And then number 5 is fostering the use of innovative technologies. And here, kind of crossing the different areas emphasized in the notice of funding opportunity, including data sharing, interoperability, expanded the use of telehealth and remote monitoring, appropriate use of artificial intelligence, and utilization of consumer-facing technologies. And that should sound familiar to you because it's also pulling out from the factors. And here, the initiative would be around harnessing data and technology. So what we end up with through this methodology of priority to objective to initiative is 5 initiatives. And again, those initiatives have under them specific programs and projects to drive the achievement of the outcomes that we've identified. So next up.
Thanks, Marty. Before we go through the example, there are a couple comments in the chat I wanted to lift up. Robert Stiles says, will you have multiple objectives within priorities?
There should be.
There's one objective per priority.
What at this point is one objective per priority, because again, our goal is to have these comprehensive initiatives. And so we're trying to build the initiatives down.
Correct. Cool. And then Denise says, community-based organizations are essential to help address root causes of diseases. They're often at risk of having negative operating margins. Without them, I don't believe we can transform healthcare. So I think a comment for including community organizations in that objective. Doug says, I'm not sure how provider to population ratios are calculated, but our counties are rather small compared to the national level, and some of our rural hospitals even serve 4 to 6 counties, even especially when considering OB services. And so, and Robert says, initiatives seem to be less specific. So I think helping go through an example of how everything has come together would be a good place to transition to showing a preview of the first strategic priority and initiative. And then we can address any questions related to the structure after that.
So initiative number 1 is like, again, a grouping of activities, again, woven together, implemented consistently across a shared timeline with common milestones. That's our definition of an initiative. And we start with the strategic priority, preventative health, as well as preventative health is that first strategic priority. The objective then is putting that into a measurable perspective, right? So realize meaningful reductions in chronic disease rates and avoidable hospitalizations for complications. The initiative then, the broader initiative, expanding primary and secondary prevention programs. So how are we going to achieve that? We have specified objectives tied to that. Specified outcomes tied to that. That then gets us to what are the programs and projects that are implemented to achieve the outcomes targeted by the initiatives. I understand this sounds like a whole lot of words right now, but being able to run an organizational principle through the narrative, and then being able then to build it into implementation plans as well as milestones and timelines becomes critical in terms of the structure of the application. Next up, Sheena. So let's go again, take a little deeper dive on this initiative 1, expanding primary and secondary prevention programs. We then said, okay, what are outcomes? How do we know we've achieved this? How are we going to measure that we've effectively performed on that objective? And you see here, there are 7. We went broad to start, and this is where we need your help, is to be in this process of narrowing these down. What we focused on doing was coming up with outcomes that are measurable, that there is data available. And so these outcomes associated with Initiative 1 are targeting that by 2031, the end of the award period, rural Kansas counties will achieve statistically significant ... We have reductions in chronic disease, specific chronic diseases, reductions in the percentage of adults with fair or poor self-perceived health status. So that's survey data that is regularly available. Similarly, reductions in the percentage of adults who report mental health was not good, 14 or more days per month. Improvements on children's performance on the presidential fitness test, and I'll come back and explain why we selected that one. Reductions in the percentage of adults who smoke, reductions in the rates of avoidable hospitalizations, and reductions in the percentage of individuals reporting low health literacy. So again, the reason we have the outcomes is to say, well, how do we evaluate that we in fact implemented, how do we evaluate the initiative achieved outcomes that are aligned with the strategic priority? And that's where we get to this level. Now, these are not necessarily the metrics we report on. We'll try the metrics to them as best we can, but this is sort of overall, how do we know if we're succeeding under this initiative?
A couple of questions come through in the chat related to those. How are objectives different than outcomes? If your objective is the overarching data outcome. Is there a reason we're only mentioning mental health in adults? The best ROI for health outcomes is to focus on our children. It's not clear where they fit. So a couple of comments on specifically calling out children in the objectives or in the outcomes. Sorry about that.
And absolutely, if there are data points we can utilize for purposes of outcomes, because I mean, an outcome is going to be, it needs to be measurable. So we need to have a baseline where we are today and a vehicle for collecting data to demonstrate where we are in 2031. And again, for a lot of you, these are going to look familiar because they're pulled out of Kansas Health Matters and data that's available at a county level through Kansas Health Matters. Not necessarily collected, all this data is collected on different schedules, on different measures, but that's the source for most of the outcomes you see here. And this is the most direct because of it being focused on prevention programs. You could identify those outcomes. Remember, objective is expand primary and secondary prevention programs. I mean, I did it myself. I'm sorry, guys. That's the initiative, right? How do we know if our initiative achieves its objective? Well, we look at the outcomes. So this is the outcomes we want to achieve. If we achieve these outcomes, we know we've met our objective through this initiative.
Thank you. Some more comments and suggestions are coming in on the chat. An agreement around diagnosis of chronic disease. That takes a long time to measure. So maybe more of a concern with reduction in morbidity from that disease. Also a comment about smoking prevention starts in childhood and potentially broadening on adults who smoke to those who use tobacco products. And Denise mentioned there could be a data for children and adolescents available through KDHE. So some considerations for outcomes for Initiative 1. All right. I think we can move ahead and go to the potential programs and projects to show this example. Thanks.
So this is, again, as you recall, folks responded to the request for ideas, proposals, projects, and I think we're now well over 200 that have come in. The application team has been sorting through those, talking with folks on follow-up, developing budgets, looking really to make sure we've hit those proposals together, hit all of the themes. And so what you see here is the preliminary building of an initiative through programs and projects. So as you see here, there are currently under Initiative 1, 5 programs. Patient-facing technologies, dual eligibles, behavioral health, food as medicine, and then the Sovereign Nations Fund. So let's go through each and why we've included each, or at least the reasoning of the team at this point. And again, want your feedback. Patient-facing technologies, again, goes to that specific factor. One of the 10 factors talks about patient-facing technologies. So there were some excellent proposals presented on evidence-based initiatives, specifically the Thrive Digital Mental Health. That's a computer-assisted cognitive behavioral health intervention that could be implemented. Similarly, there's LEAP Lifestyle Platform from Alzheimer's Prevention. There is the very well-known the Diabetes Prevention Program, which now has been structured in such a manner that can be delivered asynchronously, which is a significant change on how this program has been developed previously. So being able to leverage that opportunity. YMCA 360, again, another evidence-based program focused on lifestyle changes. And then the Telehealth Rock school-based programs, bringing preventative care and lifestyle education into the schools. So there are 5 examples of patient-facing technologies, all of which are consistent with primary and secondary prevention programs. Second category here, you're saying dual eligible beneficiaries integrated care. Why are we calling out dual eligibles under primary and secondary prevention programs? Again, it's a specific factor listed in the NOFO. That is what will your state do to address the high costs associated with dual eligibles, folks that Medicare and Medicaid dually eligible, the most expensive individuals in the US healthcare system. CMS wants to push those folks or help those folks get to integrated care. The most common form of integrated care for dual eligibles is the PACE program. Also in Medicare Advantage space, there are plans, probably DSNP is the one most folks are familiar with, which is just a high level of care management services furnished via a Medicare Advantage plan. And so that's the factor we're addressing here. Quickly realizing that PACE is a better step forward than promoting more Medicare Advantage plans. I'll leave that there. We have two organizations that have stepped up with a significant interest in expanding the availability of PACE statewide, Bluestem and Midland. And so we have projects that would focus on expanding PACE in different regions of the state. And then for those dual eligible beneficiaries who would remain in traditional Medicare, we would have a project focused on more intensive care management for those individuals, utilizing remote ambient monitoring tools. Talk about one of those proven and promising initiatives. These are coming online. Early research shows they've been very effective with this particular patient population, being able to implement that on a more of a statewide basis to manage that high cost population. Third program under this initiative focuses in on behavioral health, primary and secondary prevention programs within behavioral health. Here is the CCBHCs being integrated in adult care homes, the emergency department intervention hubs, and assessment and transport of individuals with behavioral health conditions from hospitals by CKF. The 3 projects there. Then there are 2 programs with no specific projects under them. One is the Food as Medicine program that Jody's going to be describing in greater detail. The 5th program here, excuse me, is the Sovereign Nations Fund. And this is the beginning of funds. We're going to have more conversation around this, but is creating a special pool of funds, a defined amount of funds that would be available to the 4 recognized tribes in the state of Kansas for healthcare initiatives on their reservations, which of course are located in rural areas of the state, and having it administered through the state, having those funds available to ensure they have the flexibility to introduce that primary and secondary prevention through their healthcare system. So that's how an initiative is born. It's a long ways down, but that's how we get there and organize them. So folks' response. And what are we missing? That is critically important here.
And we do realize this is the first time you're getting a chance to see the structure in an example. So we will have time in our time together on October 20th to review every initiative and the full package as it stands on the 20th. And you'll get a chance to kind of marinate on the information and think it through and provide feedback as well. Some initial thoughts coming in.
Absolutely. A question from Dr. Kraft. Absolutely. This is all written in pencil. Everything can be erased and more can be added to it. Our constraint is a budget. And so while there's some flexibility in the budget, we've been told to budget to $200 million. The NOFO states that if we don't know if we're going to be awarded $200 million, we could get more than $200 million given our scores. And so if we end up with $250 million, the NOVO says that we'll have an opportunity with CMS to determine how we're going to rebudget to account for those additional dollars. So which projects will be emphasized more to account for those dollars. So there is an incentive here to be more inclusive in the number of programs and projects. Granted, still, it's going to, it's a tug and pull process, and that's why we go back to the values, is to help us decide which one should be here. So no, this is exactly why we need this, the Alliance group, your feedback, because we're looking at it from one perspective as we pull this together. And certainly we're going to do our best to have information to you in advance, but please understand there's a lot of building it while you fly it going on as we work through the application, as we process our way through the proposals that have been received.
Thank you. Also, a couple of comments about wanting to see children addressed in the plan. So just something to note. All right. Okay, I'm gonna move us along. And once again, we'll have some additional time. Before we move to funding pools, Marty, I know you wanted to talk a little bit about a letter of support and what that might look like.
Yes. The only letter of support that is required in the NOFO is one from the governor, because the submission must come from the governor and the governor must attest to her support for the plan as submitted. But there is certainly room, particularly among stakeholders that have been engaged in this development process, to lend support. And so what we would propose to do, given page constraints, because we only have 35 pages for supplemental materials, and a significant chunk of that is going to be eaten up by the milestone timeline and implementation plan. It's also going to be eaten up by 4 pages of CCBHC addresses that we're required to submit as well. But what we would propose is a single letter from the Alliance with the signatures of an authorized representative of each participating organization. We just started working on the draft of that. We'll certainly share that as soon as it's available with you all. But the ask would be at Monday's meeting, if you are comfortable and willing to sign on to the letter of support, which primarily focuses on this stakeholder engagement process, since that is a key element of the notice of funding opportunity scoring. That would be our ask at the end of the session on Monday. And if there are organizations that are unable to attend in person on Monday, we'd certainly have a process in place to follow up to get signatures.
Okay, there's some additional questions in the chat. Thanks for sharing about the letter of support ask. Some questions about projects and where they might fall or considerations to add to the application. Ed has a comment about, to what degree do we need to identify the projects now versus identifying the programs, and then allowing more time for the state to discover the best projects to bring to those programs to fruition. These are all wonderful projects, but I imagine there are also several organizations and projects that exist that just didn't get something submitted on time. And then another question about applications for funds, which we'll talk about next. So,
well, Ed, your question is a perfect lead-in to our next topic, because it's absolutely true. There are a number of proposals submitted that sort of group themselves around certain topics. And given limited information submitted, because the submissions, we weren't requesting a 20-page detailed explanation on those, but we have general descriptions, we have general budgets and the like, and we came to an appreciation, the application development team, that in these areas, which really aren't truly statewide initiatives, they don't require that level of coordination. Let's, as part of these initiatives, create programs that are funding pools, and that there would be effectively it'd be a grant program. Is there'd be a certain amount dedicated each year to those pools, mainly front-loaded because of how these programs roll out. We'll front-load most of those opportunities. And let's use defined criteria, approved criteria, have proposals submitted, and then have those appropriately vetted funded and then have, of course, reporting requirements associated with them. So at this point, let's review the funding pools we've identified. And they, again, are going to cross multiple initiatives. So we've just discussed the Sovereign Nations funding pool, which would go to both initiatives 1 and 2. Regional strategic partnerships. Number of proposals submitted about either existing networks wanting to expand the services they provide, hospitals within a region saying, hey, we want to develop a shared service line, we want to develop shared back office services. It'd be a hospital saying, hey, we've got a great readmission reduction program that we want to help other hospitals adopt. These types of regional strategic partnerships, that would be one of these funding pools. And the thought here is to, of course, leverage good structure where good structure exists. And our friends at Grant Makers in Health potentially could be the folks who would administer this pool, both with stakeholder input, create the criteria, receive applications, score the applications, work with the state to distribute the funds, and then provide ongoing technical assistance as appropriate. Similarly, Community Innovation Fund had a number of proposals where typically individual communities were saying, we need an X. If we had a Y, we could really do some new things. So they are transformative to the individual community or spark innovation in an individual community. And again, we would propose creating a funding pool for that. Hospital capital expenditures. This is sort of a two-part fund. Part would be dollars to support hospitals that are converting to rural emergency hospital status. We've learned through the REH transitions the state has gone through. I think there are 3. Is that right, Chad? 3, 4, 3, 4, 3. Thank you. That there are some needs in terms of reconfiguring the facility, being able to, if you offer skilled nursing facility services, that you come in compliance with the SNF COPS, for example. That's funding not otherwise available. We consider the hospitals that are converting to REH, most are going to be capital poor. So making funds available to support that. Otherwise, other initiatives which would require capital for primarily remodeling or new equipment, because that is permissible within the NOFO, but creating a fund for those types of capital investments that are innovative, that they expand the capacity of the hospital to deliver services, they deliver services in a different way, they enable the use of technology. That would be in that funding pool. Workforce training and support, I will leave that to the team at KHA to discuss in greater detail, but again, a number of excellent proposals submitted. And rather than at this point try to choose winners and losers, which we don't want to be in a position of doing at this point, we want more winners, all winners, but to create this funding opportunity for those types of initiatives. Non-emergency transport. Again, this is similar to the community innovation pool, but this is specific asks for rural communities that don't have transportation available to individuals, don't have a bus, don't have an Uber service, but be able to make sure folks can get to appointments, specifically focused on fusion therapy, chemotherapy, dialysis. The data shows that lack of transportation to those types of services obviously lead to more significant complications, more significant expense. So creating that ability for communities to develop a sustainable plan around non-emergency transportation. Also address here folks with disabilities who require transportation for activities of daily living, creating a vehicle for that when it's not otherwise covered by Medicaid. And then the technology adoption supports projects. This goes both again to consumer-facing technologies, again, that factor that's critical in the application, as well as the use of artificial intelligence. We've heard repeatedly from folks that, yes, they keep telling us that AI is going to be critical, that AI is going to change things, but I don't have any means to evaluate AI technology. I don't have the capacity to implement AI at our facility without a very clear roadmap for accomplishing that. The purpose of these projects would be to have a team of experts convene, do that vetting, kind of the good housekeeping seal, that then rural providers would be able to leverage that information. Those experts would also develop those implementation roadmaps, and then dollars would be available for the rural providers to implement those solutions. So those are the working program funds. Again, as Ed, you noted, it's difficult at this point to get down to this level of projects, given just the incredibly condensed period of time we're working in it. Again, I think I said this last time, but what I would do for a planning year under the size of this grant and what we could do with it. But we are instead building it as we fly it. And so this is our partial solution. It's not necessarily a point winner for purposes of the application, but it's the right thing to do to really foster innovation. So under each of the initiatives, our goal has been to have one true, strong statewide project that matches, that will cross several factors, but then also, as you see, create these funds within that initiative as well. There. So this is our breakout, right? Sheena, is this where we go from here?
Not quite. We're gonna have a
Oh.
discussion about about the funding pools, and then we're gonna go into breakouts.
Okay,
I promise
got
to
it.
get us into breakouts by 3:15. So we'll play
Okay.
a little catch up. It's a lot of information. So, all right, we can go ahead and go to the next slide. All right. So we did have an initial breakout discussion during the last meeting about potential program funds. We asked about guiding principles. So what are principles that could guide the funds? What should the structure, criteria, and outcomes be related to the funds? And what are some potential projects and partnerships that would be important to consider for the funds, which you can see reflected in some of the examples Marty just shared. So I'll go over a few key pieces of the feedback. But as I do that, we have a few questions that Lindsay is going to put in the chat for you to think about. You can answer 1 or 2 or 3. Provide any of your thoughts related to guiding principles, criteria and outcomes, and projects and partnerships. And Lindsay, I'll go ahead and ask you to put all 3 questions in the chat as I go over the feedback. So in terms of what people talked about, they were asked what should really guide. There was strong agreement that the funds that were to put in place should be sustainable beyond the initial funding period. They should be replicable and scalable. They should maximize impact for meaningful change, and they should promote and build upon existing partnerships with an emphasis on collaboration. They should have a straightforward application process that removes barriers to access, like someone said, little red tape. And a clear vision for sharing how the pools are innovative and transformative for Kansas. In terms of the structure and how the fund should be designed, there was a suggestion to have a multidisciplinary stakeholder group to review the applications for the funds, to ensure the review process has clear criteria for the fair distribution of funds, and that goes back to having a clear vision and making sure it's not a barrier to apply for funds, but to make sure that everyone knows what's expected. It's also suggested to consider the size and capacity of the organization when determining funds. And so whether that's their ability and capacity to apply, or what is awarded, the capacity to distribute the dollars. Provide incentives or require collaboration between sectors as a condition of funding. So this is thought was considered match resources or requiring match from other organizations. Maybe it doesn't have to be money, but some sort of resources to indicate buy-in. Expecting realistic outcomes for the funding period that would apply. In many cases, I believe it's a 1-year funding period at a time. And then in order to measure outcomes, leveraging data already collected to be reported by applicants when possible. And that could alleviate some burdens on data collection and reporting. Some projects and partnerships discussed were opportunities to infuse healthcare into other existing systems like jails and courts, projects to extend shared services, bridge funds to other delivery systems like rural emergency hospitals, behavioral health integration, which was mentioned, and is there consideration around regional funds or regional partnerships as it relates to funds? So that's in a nutshell what was discussed in the breakout. So if you have any other thoughts on the previous discussion or the questions that were posed in the chat, we can go ahead and hear from folks now. And they can share thoughts. Please share your thoughts off mute or in the chat about your initial reactions about the funds. Denise says, I'm not sure this has already been considered. If not, encourage looking at an integrated referral system between community-based public health programs and clinical care. There's a well-used referral system, IRIS, and there are existing and well-tested referral systems that can easily be integrated into electronic health records. Any other thoughts about what might be missing? What criteria should inform the funds? Robert says, in addition to Denise's comment, community-based organizations that impact social drivers of health. So social service organizations, etc. Okay. We have about 1 more minute, so if you want to review and continue to think and answer the questions. A comment from Carrie, is it anticipated that organizations would apply for and receive funding from these pools in year 1, or would there be ramp up time? Good question.
Remember, we have to spend any funds that are received in year 1 by October 31st, 2027. So we will get those funds out the door.
In fact, as we're thinking through the 5-year budget, as Marty said, because other programs ramp up over the 5 years, it's important actually for us to get the money out the door, starting in year 1 and 2, from strictly a budget perspective. So absolutely front loading the funds in the first few years.
All right, thank you so much, and thanks, Jody. Ed says, what is the range of monetary awards from these funds?
Currently the range, and again, this is a very preliminary budget because obviously all this stakeholder input then changes the emphasis under the initiatives, which then changes the programs and impacts the budget. But preliminarily, the funds range from $2 million a year for 3 years to $12 million a year for 3 years.
Jody, real quick, that's super helpful. Do you all have, do you imagine what the size of these actual grants would be to organizations or communities that would be receiving these funds? I'm trying to get my arms around, are these $10,000 micro grants? Are these are they $350,000 grants? Are they $1 million grants going to a community or to an organization? It just affects how I think about some of the questions. And if you don't have an answer right now, that's okay too. Totally understand.
Well, I can tell you the thinking currently as we're developing the budget is that would be reflected on the impact of the application itself. So some of the regional partnerships coming in are supporting a region of 12 or 14 counties, which would require, a significant multi-million-dollar investment. Some of them are, I need a mobile clinic to take my rural health clinic and meet the needs of my communities that are further out and don't have transportation to get into our county seat. And so it would, from what we're envisioning, it would vary, not with a hard and fast dollar figure, but would vary by the impact of what's been proposed, which would be up to the multi-stakeholder group who is providing input to the selection to determine the level of funding appropriate given the impact of the program. Now, Dr. Mosier, Marty, anything you would add to that?
I just want to note Brenda Sharp's question, what would be the role for grant makers in health? And Brenda, our model is Sunflower's work on the opioid settlement, and having your expertise, all of the grant makers' expertise in running these types of programs, administering these types of programs, rather than, of course, reinventing the wheel. We would take the excellent wheel that already exists and leverage that. And certainly, of course, as I think we've mentioned previously, 10% of this award is allowed for administrative overhead and services. So it would not be without proper compensation for doing that work.
Thanks, Marty. This is Brenda. I just wanted to clarify that Kansas, I'm sorry, I don't know what's going on there. That was weird. Kansas Grant Makers in Health is a loose collaborative. We are not an organization in and of itself to accept funding. We do have an opportunity fund that is established at the Topeka Community Foundation that occasionally our members contribute to and do some joint funding. So I just wanted to be sure we weren't overrepresenting in the application the structure. Individually, I think foundations could potentially serve in that role, but I just wanted to be sure it was there wasn't an expectation that there was like a formal vessel there established at this time.
No, we just thought it best for you all to decide which of you wants to move forward with that. We don't pick winners and losers the best we can.
Gotcha.
And in that one, we'll let you all decide.
Okay, thanks.
Okay, I did want to note that we will summarize the notes from the previous group discussions and the key questions and comments that were raised, so that I can move us on to breakouts and we can share any responses and how that input was taken into account following the meeting. But in order to move us along and to get to the engagement, the more detailed engagement, I'm going to do a breakout group preview. So preview what the breakout discussions are going to look like today. We are going to go into 3 breakout discussion rooms today. 1 is focused on workforce, 2 is focused on food as medicine, and 3 is focused on EMS. So now that you know a little bit about the structure, we're really going to be looking at the program and project level. And so you'll have a member of the application team or stakeholders that have been working on each of these topics for the purposes of the application, to give you a little bit of context and how that particular topic area is coming together and showing up in the plan. And then you'll have an opportunity to provide some feedback on those particular items. And so in order to catch up a little bit, I'll ask our presenters to keep it to 5 to 7 minutes so we have some additional time for discussion. We will be using Padlet again for the discussion, and facilitators are there to help take notes on the Padlet for you. You can share your thoughts in the chat or come off mute. You do not have to use the Padlet tool, but our facilitators will be taking notes and they'll be capturing comments on the Padlet for the quick turnaround to the application team so that they can capture your input as they're finalizing the application draft. And as a reminder, you'll have an application development team member and a facilitator and note taker at KHI so you can have maximum engagement opportunities. So we really appreciate your input and thoughtful discussion, and we'll go ahead and open the breakout rooms now.
If there's some folks in this main room still who need to be assigned or want to be assigned to one of the other rooms, just let us know. And someone can move you to either workforce, food is medicine, or EMS. Oh, Jessica, are you trying to select? Tell me which one, 1, 2, or 3 you want to go to. 3, 2 food is medicine or 3 EMS? Food is medicine. I'll move you right there. Thanks. Oh, you're gone. I think somebody did.
All right. Welcome back, everyone. I know everyone had great ideas, thoughts, discussions, reflections in the breakouts, and thanks to our facilitators and breakout presenters for providing context to have meaningful discussions. We'll go ahead and share out key points from each of the discussion rooms. So first up, we'll be hearing from Cynthia with the workforce discussion group.
All right, so lots going on in workforce that it was a great to hear all the potential projects that could come into the workforce areas, and really many of the workforce is with you can't do the other projects unless you have that high quality, the amount you need of allied health. So that was really kind of an underlying theme, was that workforce is important in and of itself, but then it also feeds many of the other initiatives that the groups are talking about.
Thanks so much, Cynthia. I'll turn it over to Shelby with Food is Medicine.
Yes, we had a great conversation in Food is Medicine today. So we looked at a few different proposals. One of the ones that we talked the most about was the potential plan to put 100 CHWs across rural communities in the state to help facilitate the Food is Medicine program, as well as some of the collaborations that we're looking at between entities like K-State, Sunflower Foundation, and others to really bring this vision to life. So one thing that we did bring to attention that maybe was a gap was right now there's just less access to high quality produce in rural communities. So thinking about how we can get that kind of produce and those types of resources out to rural communities. So great discussion, and I'll turn it back to you, Sheena.
Thanks, Shelby. And we'll hear from Wyatt next for the group focused on EMS.
Thank you, Sheena. Our group was talking about EMS and really discussed EMS transport proposals and ideas, as well as efforts to enable treatment in place. Some of the discussion really focused on the challenges and potential opportunities related to workforce, the role that mobile integrated health and community paramedicine as a model could play in facilitating addressing some of those challenges. Reimbursement was a topic that came up as well. And a final cross-cutting idea is the need to partner with local entities and local collaborators in each of these communities. Really good discussion. Those are some of the highlights.
Thanks. And yes, Carrie, time does really fly in breakouts. And we'll get, like I said, on Monday, we'll have 4 hours together to discuss more and to reflect on the plan. But now, as we're coming to the end of our time together today, I'll turn it back over to Secretary Stanek and Secretary Howard for our closing.
Okay, it's on mute. Okay. All right. Well, thank you, everyone. As we wrap up, thanks for the thoughtful discussion, ideas, and feedback. The engagement here is going to drive the process forward, as you know, and I hope the breakout sessions shed a little more light on the iterative process to get to the goals and the strategies that we want to, a little more detail sharing. And I think it'll become clear as we move forward. Today's discussion will help us refine the development and the continuing refinement of the application. And for those of you that joined us, our partners live streaming today, thanks for your commitment to this effort as well. We want you to stay committed to our process and stay connected and continue sharing ideas. We did post the entire notice of funding opportunity document on our KDHC Rural Health Transformation Plan website today. If you want to look at some of the reasons of what Marty was elaborating on related to the restrictions and the 35 pages here and budget restrictions there, it might become a little more clear to you why this is a little tricky to get completed. But thanks again to help us advance rural health in Kansas. I'll turn it over to Secretary Howard for any closing comments. Thanks, Secretary Howard.
Hey, thanks. I want to thank the KHI for kind of facilitating this, and thanks for Marty for all of her time that she spoke today. Yeah, thanks everybody for the engagement. You know, I think days are always hard when we're trying to sort out the definitions of, strategies and programs and objectives and those things. So thanks for hanging in there. And I know and that can be even harder sometimes virtually. So I really, really appreciate the engagement. Again, I would just echo the thanks and say how much I look forward to seeing everybody on Monday, where we can really spend some good time together in person to really advance the application. So thanks everybody for being with us, and thanks for committing to be with us again in a few days. Thank you.
Okay, we'll turn it back over to Sheena now for closing remarks and reminders. Thank you.
Thanks so much. Thanks to both of you and for all of you today for joining us. We have a brief one question evaluation that will help the facilitators and the application team ensure that the process continues to be engaging. So if you'll take some time to share that and complete that, that would be great. We also put a link in the chat for you. And as we've mentioned, our next meeting is October 20th from 10 a.m. to 2 p.m. And you'll receive more details and information about that ahead of the meeting. We plan to share materials if they are available in advance, but understand that the time frame that we have is very rapid, and we thank you for your patience and understanding as we prep everything for you to react to. We hope that you have a great rest of your afternoon and weekend, and we'll see you soon.